morning, everyone. Welcome to Pediatric Grant Rooms. I almost said welcome to St. Patrick's Day. We've been talking about green for a minute. All right, today's speaker is Dr. Andrew Hayes, one of our third-year residents. Dr. Hayes is a graduate of Campbell University. During his time at Carilion, he's been involved in multiple projects. He's been on the resident committee to improve communications between physicians and nurses, order set development, peer support networks, evaluation committees, and he serves as the vice president of the House Staff Association. Dr. Hayes plans on, well, he will be our fourth-year chief resident, and he plans on pursuing a career in critical care medicine. His faculty advisor for this project was Dr. Violet Borowicz. Please join me in welcoming Dr. Andrew Hayes.
Thanks, guys. There's a lot of people online, not many people here. That's great because it takes away the pregame jitters a little bit. I appreciate it. But thank you for the nice introduction, Dr. Permishwar. I appreciate it. Like you said, I'm Andrew. Most of you guys know me. Been here in Roanoke for several years now. There's something in the air in Roanoke because my suit is tighter than it was. My hairline's receding, so I don't know what's going on here, but that's okay. But like I said, I'm Andrew. We're going to be talking about a little bit of Onco critical care things today. The title of my presentation is Stories from Memphis. And the reason I'm doing this is, hold on one second, there we go. I was honored and blessed enough to spend some time at St. Jude this past year. I did a 4-week rotation there in their pediatric ICU. It was quite a wonderful experience. I learned a lot of things, met a lot of great people there. If you see on the picture with the actual St. Jude campus, the building here in the middle, that's actually their clinical hospital. The rest of those buildings are a lot of research. Of course, they do tons and tons of research in pediatric oncology and hematology. So in their pediatric ICU, it's a 12-bed ICU. They take about 350 to 400 admissions a year. Their patients typically stay a lot longer than ours. Their length of stay is significantly longer, as you can imagine. A lot of these patients have some pretty awful complications of their cancers and their treatment. But it was quite a wonderful experience. In the top left, that is the Memphis, I guess we call it the Coliseum. This is a southern town, if you've ever seen one. So this is where the Grizzlies would used to play, the professional basketball team. But they since have built a new one, so they made it into a big Bass Pro Shop. Like, that is some Tennessee stuff. That's fantastic. But anyway, it's a lovely city, lovely people. And it was honored and blessed to be able to spend some time there. And the point of this today is to kind of just go over a few things maybe I learned. We can take it back here to Roanoke and try to help some patients. So our objectives are to review select topics that pertain to pediatric critical care oncology. We'll discuss some recent updates and discoveries that may be pertinent to treating these patients. Then we'll try to increase the comfort in dealing with some of these patients and their disease processes, because even though they're common out there in a place that only deals with onco critical care, it's also not uncommon here, even if we don't catch it all the time. So we're going to do it in a case-based fashion, just so hopefully you can try to remember some things and learn some things that way. So first case A is a 17-year-old athletic male. He's a D1 recruit. Basketball player. He presented with a week of worsening cough and difficulty lying flat due to shortness of breath. He got tested for COVID about 18 times. It was negative every time. A chest x-ray at the outside hospital shows a mediastinal mass, and then eventually a CBC was done, which showed a white count of 100,000, with the majority of these cells being blast cells. Electrolytes, we're told, are reportedly normal. At the outside hospital, A is giving 2 liters of normal saline, has to wait about 12 hours to be sent from 2 states away to St. Jude for treatment for this malignancy. While he's waiting, he's given a couple more hours in D5 with some potassium in it. By the time he arrives, his potassium is now 6.9. His creatinine is now 2.1. He's complaining of a funny feeling in his chest. So unfortunately, this is not an uncommon presentation of something called Tumor Lysis syndrome, which we do see not uncommonly. It's actually the most common hematologic oncologic emergency. What happens basically is a rapid breakdown of friable malignant cells, releasing all their contents into the bloodstream. It's hard to find morbidity and mortality data on this. I couldn't find any great resources, but every resource I found said if you don't do anything about it, the mortality is high, as you can imagine, from having all this extra breakdown product in your body. What's important to remember about this is that it can technically happen with any malignancy. It's most common with high-grade lymphomas and leukemias, rapidly proliferating tumors. I put Burkitt's in its own category. Now, that's a leukemia and a lymphoma. But commonly on your board exams and even in clinical practice, that's something that you'll hear that's the one, because the doubling time is so short with that type of malignancy. There's case reports of it happening with colon cancer, CLL, CML in the adult patients. So you have to keep in the back of your mind, even though it's less common with some smaller cancers or things that are better differentiated. But It can happen with any malignancy. Also, as you can imagine, having a pre-diagnosis of renal disease, sepsis, dehydration, hypotension, any other big medical problem on top of having this significantly raises the risk of this syndrome occurring and then thus having problems from it. So this is pediatric, so I can make cartoons, sorry. You'll see a few times, you'll see this unhappy smiley devil face thing. That is our cancer cell, okay? So the pathophysiology, we're gonna go over 4 different conditions, but every time you see that face, that's the cancer cell we don't like. So what happens in tumor lysis is you have a bunch of these cancer cells, and over time, you hydrate the patient. Sometimes when you actually start chemotherapy, when these cells start to break down, and sometimes it's just time, particularly with the Burkitt's that I mentioned before. If the malignancy is there for long enough, these are friable cells anyway. So if they continue to replicate at a high rate without any kind of therapy, they might start to do this on their own. We actually had another case of a patient that showed up in Florida tumor lysis syndrome when they had nothing but time. And there was no treatment was administered. They went to a primary care, got a CBC, and were in trouble by then and had to get flown from a couple hours away. So just keep that in mind. So any one of those things, hydration, chemotherapy, time, these weak, friable, malignant cells start to break open and start to release a whole bunch of fun stuff. Potassium is pretty self-explanatory. It can be dangerous if you have a bunch of potassium. Remember that the potassium in these patients is not like our DKA patients where they're total body depleted, but they're acidotic and it's all over. This is true, quote unquote, exogenous potassium that is coming from broken cells. So they're total body, exceptionally high potassium, and it's in places that you don't want it to go. Second thing that gets released pretty frequently is phosphate. Phosphate by itself can cause a few problems, but the one big problem that it does is it binds all your free calcium in your body, right? So that leads up to hypocalcemia, which that causes some very significant problems, of course. Next thing that comes out a lot of times is cytokines that get released. This will cause a pretty significant inflammatory response in the body. You get some hypotension, some general inflammation, and that can lead to a pretty bad acute kidney injury. And by the way, all the free calcium that's hanging around there, all the hyperphosphatemia is binding all of the free calcium and causes calcium phosphate crystals to precipitate in the kidneys, and even worsening further your acute kidney injury. One of the last things that can happen is, of course, you have all the DNA breakdown products that come from the malignant cells. Remember, DNase breaks down DNA into purines, which then metabolize into hypoxanthine, which then, using xanthine oxidase, turns into xanthine, and then xanthine oxidase again to uric acid. Remember that these are also not very good. So this is also going to lead to an acute kidney injury. You have uric acid and xanthine buildup. So the moral of the story is there's a lot of bad things that can lead to acute kidney injury in these patients, and that's really what you have to be very careful with these patients. As you can imagine, this makes a patient that already has a renal problem and really bad, dire straits when this gets pretty bad. How you make the diagnosis of this condition. So it's relatively simple, luckily. 2 or more of the following 3 days prior to or within 7 days of starting any therapy. And the key I want to lay out is 3 days prior to. Again, time sometimes is the only thing that needs to happen for this ticking time bomb to go off. So if you have a patient, you're concerned they have a malignancy because they have a large mass, they have a high white count, they're pancytopenic, whatever. You also notice that they're hyperuricemic, hyperkalemic, hyperphosphatemic, or hypocalcemic. That should get your radar going a little bit. This is the Cairo and Bishop classification, which obviously some smart guys named Cairo and Bishop are the ones who made this up as far as making the diagnosis. But it's relatively simple. Sometimes also the diagnosis can be made if there's any type of symptoms with these. So I have a patient that has high white count, they feel awful, and all of a sudden they have tetany from their hypocalcemia. That's enough. You don't need to, you should always monitor the labs, but that's enough to make the diagnosis. You need to start going down this pathway of what we're going to do about it, because it's that dangerous. We're talking about the treatment for it. It's relatively simple. You've kind of followed the physiology, that's why we took the time to go through it. We'll first start with electrolytes in the kidneys. So your standard therapy options apply for the electrolytes as far as potassium and phosphate. You want to limit intake, so don't give them potassium fluids. If they are eating, which a lot of these patients are quite sick, you give them phosphate binders to make sure they don't absorb any phosphate. The other thing is the most crucial part is you need to maximize excretion. So perfusion to the kidneys particularly is key. These patients usually get hyperhydration. It's like 2,500 to 3,000 mLs per meter squared per day. So you target a urine output of like 2 mLs per kilo. And these patients are peeing like racehorses. And that's what you need to do to continue perfusion and try to get these electrolytes out as best you can. You also very early on consider dialysis in these patients, and particularly if you're having problems with calcium. So you have hypocalcemia, you start to have cardiac effects from that, as well as hyperkalemia. So it's a double hit to the cardiovascular system. As well, hypocalcemia can precipitate hypotension and really feeling quite awful. So you say, why can't I just give them some calcium? Their calcium's low. Remember, their phosphorus is really high, right? So you give them calcium, the phosphorus is going to suck it up real quick. It's going to bind again, go back to the kidneys, cause more problems. I'm not saying if you have a patient with EKG changes and palpitations, don't give them a little bit of calcium while you figure out what to do, but just be very, very careful. And the things that were told to me is when you start having problems with calcium and causing cardiac effects and causing other issues, that's when you really need to put call your local nephrologist and at least have them on standby, I'll put it that way, because you really need to consider dialysis, particularly with the calcium issues in these patients. Now, as far as the treatment for the DNA breakdown products, these guys cause problems on their own. So what we do with this is, typically what's been given is allopurinol, right? So that blocks xanthine oxidase, but it doesn't really do anything to stop uric acid that's already present. So remember we went through before. You have xanthine oxidase goes to xanthine, and then it does it again to uric acid. So it cuts out the middleman there, but you already have xanthine buildup and you already have uric acid. It can take a couple days for those to go away, okay? So you already have a high uric acid level, it's already trashing things. You can stop the fire. You can stop the fire from getting worse, but the fire is still burning for a couple days before your body is able to clear it. That's if your kidneys are working well. We just talked about how much they're getting hit in the last slide, right? So you see the problems that kind of come up with this. I saw one case there, and it's becoming more and more prominent in the literature, talking about xanthine nephropathy. The mechanism is not quite clear, but not only does the buildup of the uric acid cause problems with the kidneys, but then even the buildup of xanthine can cause problems with the kidneys as well. What's more common use nowadays is a drug called rasburicase. It's a recombinant uric oxidase enzyme, say that 3 times fast. It directly breaks down present uric acid into allantonin, which your body clears with no problem. Relatively new drug. It works fantastic. We have it at our institution. We use it frequently in patients that need it. It's stupid expensive. Per Google, it's like $37,000, so you don't misprescribe it, or it's half a resident's salary, or we'll have to take it out of Dr. Eames' check. So it's something you need to think about and talk with your oncologist before you give it, but it is a game changer in these patients because it does help a little bit with the breakdown product problem. As far as, I got this kid, he has this leukemia, or he has this lymphoma, or this tumor, and what do I do? And are they really high risk for tumor lysis? That's a great question. It's very gray. As you can see from the nice gray breakdown, this is a wonderful review article in New England Journal of Medicine from St. Jude, actually. It's not perfectly clear. Now, there's some stuff you need to look at as far as, so they even put in there a small, medium size, large size, assess cell lysis potential. Your oncologist can help you make the decision of, is this a high, turnover tumor or not? But it's still not quite clear. And unless there is a negligible risk, which is basically a tiny, tiny small tumor that you're catching real quick and cutting out, if you notice here, all of the categories on the bottom at least recommend daily monitoring and IV fluids at the very least, to the point where even the more critical patients are doing every 4 hours and sometimes even every 3 to 2 hours if their stuff keeps rising or they're already on a dialysis circuit. So I hope that kind of beats in your head a little bit about how this is a fast-moving, emergent problem that, particularly if you smell it coming or you can see that the problem's already cooking, is something you need to kind of get on top of with these patients. Some other pearls, again, I can't say it enough, is think about renal replacement or dialysis sooner, particularly with really bad potassium and calcium problems. That's when patients get a lot of trouble with this. Typically now the standard, quote unquote standard, is you consider avoiding urinary alkalization. That was a standard of care for a long time. We still do it on occasion if we have to. The old standard was, you keep the urine pH at about 6.5 to 7. And what that does is it really helps to increase the uric acid solubility and able to help the kidneys clear that. So that's crucial. The uric acid is going to trash the kidneys. We need to get it out of the body as fast as possible. The other problem with it, though, is that it also increases calcium phosphorus solubility. So you're going to help fix the uric acid problem, but you're going to make the calcium phosphorus problem, you could make it worse. So in this country, in places that the rasburicase is available and the patient can have it, we typically, the guidelines now are more use rasburicase. That's more of a second line if something's not working. It's not available in every country. It's also stupid expensive. It's not available in every hospital in the country. So you do what you have to do if that's that's what you have to do. And of course, if rasburicase does not mix well with patients that have glucose 6-phosphate dehydrogenase deficiency, so it's something you need to test patients for. You have a patient in the clinic If you're running some labs for Dr. Borowicz before they, you know this is some kind of leukemia, something's going on, add that to your list of labs to get that, because it may dictate our treatment tomorrow or the next day when we're doing stuff in the hospital, okay? Because that, you can cause a whole host of problems. Obviously, if you give a patient with G6PD deficiency or aspiricase, even though you're trying to help one problem, you're gonna cause a whole other thing, So again, we're kind of rapid firing through these cases. This is just some really good tidbits, hopefully, that we can take home. So we're going to kind of jump to case 2 here. B is a 10-year-old female who had a primary care appointment today for fatigue. She had a CBC. Really wonderful doctor in kind of the middle of nowhere, Louisiana, and got CBC at 8 o'clock on Monday morning, and then Tuesday at 2 o'clock in the morning gets a phone call from the hospital. His white count's like 120. There's a bunch of cells that look terrible. What are we going to do? They try to call the family 18 times, finally get them at like 9 o'clock in the morning, so you need to go up to the emergency department, the Franklin Memorial-sized emergency department immediately, and they're going to be on the phone with somebody who can get you some help. So, almost 24 hours is on the later, the young lady's on the way to the emergency department, starts to have some shortness of breath and some confusion. So what we worry about in these type of patients with this type of presentation is something called leukostasis. So this is kind of a cousin of tumor lysis. It happens in the same type of cancers sometimes as tumor lysis, but it's basically a hyperleukocytosis in new onset leukemia. It is a little bit more common in AML patients, which again, sometimes particularly in the primary care, the emergency department, you're not going to notice it's AML, but keep that in the back of your mind. If it's on your differential, AML is a higher MCV typically, so you already have a lot of cells and now they're bigger, right? It's very simple. It's just like plugging up a drain in your house. You have a lot of gunk and now it's bigger gunk. You can have more plugs in your drains, okay? This is something to consider. So the pathophysiology behind this is relatively self-explanatory, but I like making cartoons, so here we go. So you have the malignant cell, and you have a lot of the malignant cell, and it's clogging up the larger, arterioles and arteries and veins. Not a huge problem in your vena cava or your aorta, but when you break it down to the capillary level, that becomes a very big problem if you're obstructing multiple capillaries in different places. The two most common places we have problems with this are in the brain and the lungs. So these patients most commonly will present with neurologic and or pulmonary symptoms, so confusion, somnolence, dizziness. For the pulmonary system, they have dyspnea, hypoxemia. A lot of these patients sometimes can have a diffuse alveolar hemorrhage, and even respiratory failure can advance quite quickly in these patients. The diagnosis is relatively simple. You have hyperleukocytosis, and you have some symptoms of end organ damage, likely from like a quote-unquote obstructive process from the vasculature. So you look out for lung symptoms, again, dyspnea, hypoxemia. The pointer's awesome, but it reflects off the TV, so you can't see it. It's okay. Dyspnea, hypoxemia, you may have, again, diffuse alveolar hemorrhage, which is quite common, and we'll get to why that happens in just a second. In the central nervous system, you can have, confusion, somnolence, dizziness, headache. How many kids do we have that at 2 o'clock in the morning, particularly, they're somnolent? It could be something you could miss if you have to drag them to the emergency department at 2 o'clock in the morning. But it's imperative in these patients that you wake them up proper and do a proper neurologic exam, and don't try to write off things to the 10-year-old being, or the 8-year-old being tired at 3 o'clock in the morning, because we could miss some of these symptoms occurring. As far as the treatment for this is basically start to treat the cancer. You do cytoreductive medications. Hydroxyurea is often given in these patients to try to help reduce the burden. The data is not fantastic, but it's still often done. It's not the wrong answer. It's one of those things we've been doing for years. And does it help? Maybe. Does it hurt? Probably not. So if we're in a bind, we need to treat the patient. Let's go ahead and do that. A lot of times high-dose cytarabine, because that works quite quickly, particularly the AML patients, is instituted as quickly as possible. And then another treatment that's very commonly used is leukapheresis. So we're going to talk about that for a second, because that's important in this therapy, and this is where we can get into trouble, right? So what leukapheresis is, again, which is I'm going over a lot of things, so I think we'd have a whole 3-hour lecture on this, but you pull white blood cells out of the system, replace the plasma and other cells, and put the blood back in. Think of it like a dialysis circuit. They actually do it in the dialysis unit, and instead of pulling out the urea and all other stuff, they're basically pulling out the white cells. So the problems with this, we have to get central access with a nice big old central catheter in a patient that has a malignancy, and they are obviously at a very high clotting risk because their blood is full of all these other cells that are hypercoagulable. So we have to put a nice large catheter in a central vein in a high clotting risk patient. That's a risk. Also, they're at a high bleeding risk because how many cancer patients are very thrombocytopenic to begin with, and the platelets that they have are probably not working too well because their bone marrow has been infiltrated. So we have to worry about a clotting risk. Additionally, why I say hypocalcemia and anticoagulation is most of these patients are put on something called citrate on the circuit. Citrate will block free calcium. Calcium is crucial for the clotting cascade. So citrate goes in the machine as the blood's coming out. It mixes up in the machine, keeps the blood from clotting, and then in theory you add a little calcium at the end to negate the citrate. Well, we're not perfect and the machines aren't perfect, so it almost always will have some calcium problems and will almost always increase your risk of bleeding. So now you have a patient that has a central line that's high clotting risk. They're also high bleeding risk because they don't have very good platelets, and you're taking away some of the ability of the blood to clot anyway. So there's two big problems there. Of course, another problem we have to worry about is hypovolemia. We're taking blood out in large volumes. Now we're trying to replace it with plasma, but we still have to take it out. It's at least 10%, sometimes 20%, depending on the size of the child, how much blood comes out of their body at one time. That's a lot of blood. It's not much blood for a large man like me, 10%, but for a 5-year-old, that can cause problems, especially if they're already anemic, because cancer patients are never anemic, and now we're pulling a bunch of red cells out because I can't just pull reds and whites until the end. So you see how this is not let's give them leukapheresis and don't think about it therapy. The other question we have to consider is it helpful? It's done very often, but there's a large systematic review in 2014 that showed that there's really not a long-term difference in morbidity and mortality in these patients if they get leukapheresis or not. It's still done quite often. In some resource-limited countries, they'll actually do quite literally an old-school phlebotomy and drain them and give them red blood cells on the other side. It makes us feel a lot better. It always makes us feel better because you can check a CBC after 3 hours leukapheresis and their white cell count goes from 120 to 50. We fixed them. But remember, the problem is the bone marrow. The bone marrow is spitting out all this nastiness. So you haven't fixed the bone marrow yet. We have to treat the cancer for that. So it's a similar analogy to if I have a bathtub overflowing with water and I get a pitcher and I take a bunch of water out and pour it down the sink, I feel great about myself, but I didn't turn the bathtub off yet. We haven't fixed the problem. I'm not saying don't do it. I'm a third-year pediatric resident. Don't take my word for things, but it's something you should consider when you have these patients before you just say, let's give them leukapheresis because they're having symptoms or whatnot. Just think about it a little bit more in depth as far as what are we going to do for them. And this study I mentioned before, the big meta-analysis, was out of Toronto, a hospital for sick kids. It's a wonderful hospital that went over all the data to try to figure out if it was going to help. So a big pearl for both of these conditions together, leukostasis, tumor lysis syndrome, and sometimes DIC can and often run together. So that's why these patients are typically admitted to the hospital, if not the pediatric ICU, very quickly when you suspect this even. It only takes a day or two for these things to really cook and become a major problem. As far as long-term complications of these conditions, I was having some trouble finding some good data. As you can imagine, that you have a condition that's highly dangerous and malignant, it's going to hurt you anyway, that's why we have to treat it. So a lot of the data is focused on the survival of that cancer itself. There was some good mentions of, particularly in those who have tumor lysis syndrome, of long-term renal failure because of the fact that perhaps it wasn't treated quick enough, or that there was dialysis was not initiated fast enough, and they have trashing of whatever, you only have a couple million tubules left instead of the 10 million you were born with kind of thing. So that can be an issue. So these are some of those things as complications of the cancer and complications of the treatment, but you have to still treat them obviously, or else it's going to be quite fatal. So I hope that kind of sticks in the head a little bit with these patients. And I forgot to mention at the beginning, I don't have the chat up. If you're chatting, Janie will let me know if there's questions. I apologize about that. But anyway, we'll keep on keeping on because the time is getting short. So case number 3, C is a 4-year-old female presents to the emergency department with unrelenting fevers in the past week, because we never see that in the emergency department. Her physical exam shows tachycardia, pallor, and hepatosplenomegaly. Her gets some baseline labs, good job. Her labs are significant for pancytopenia, hypertriglyceridemia, and hyperferritinemia. I am lying a little bit because the emergency department didn't draw the hyperferritin or the triglycerides, but I wouldn't do that either if I was in the emergency department. We got those later. But this is something that should be quite concerning because we have a patient that is quite suspicious for malignancy, and then we have all these other weird labs. Is that just the malignancy? What's the problem here? So what we have to worry about in these patients is hemophagocytic lymphohistiocytosis, or HLH. I'm not going to say the first one 18 times because I'm tripping over myself, but so HLH is a condition, it's characterized by severe systemic inflammation. It's often fatal if not corrected and identified. There's multiple subtypes of HLH. I'm going to breeze over the other ones just so you know you've heard of them before when if you're ever worried about this in your differential. So primary and familial are more genetic issues. Primary, there's inborn inherited immunity. Familial, there's a genetic defect of certain genes that tend to run in families. You can also kind of throw EBV in this because EBV has been known to mess up your genes a little bit. EBV does all things. It can lead to a higher risk of HLH. This is out of the guidelines for HLH as far as the various genes and familial conditions that can be associated with HLH. The treatment for them is a little bit different, but we kind of know what it is. We know it's this gene. You have a broken gene. That's how we fix this. Most of these patients need bone marrow transplantation, so we're not going to get into them too much. But just in case you hear that somewhere else, you're like, wait a minute, we talked about that. That's not what he said in the presentation. That's what these are more referring to are the genetic causes of HLH. The other subtypes we'll get into a little bit more. Secondaries, we're going to focus our time. That is something that is acquired through an usually infectious and malignant process, some type of trigger that causes this response in the body. The fourth and fifth kind of type you might hear, if you hear macrophage activation syndrome, that's HLH occurring during rheumatic disease. Very similar process, similar treatment therapies. Your rheumatologists have helped guide you there. But that's, if you hear that word, think about it's similar to HLH, similar in that regard. But that's typically like I have rheumatoid arthritis, or I have GI, I have a rheumatologic condition we identified or not. And now this very similar process is happening. The last one is kind of call it 4.5. It's kind of like a cytokine release syndrome. It's HLH due to CAT T cell or BiTE therapy, which we're all familiar. I'm just kidding, I had to look that up too. So CAT T therapy is chimeric antigen receptor T cell therapy. That's a immunotherapy where they basically try to change the T cells and then put them back in. As your body basically will have such an immune response, but sometimes that doesn't work and you get this massive cytokine storm. And the bispecific T cell engagers or BiTE therapy is monoclonal antibody therapy. It's an anti-cancer drug investigation. They kind of try to direct the T cells and the patient's own T cells and change the immunology of those cells. And unfortunately, they can have this type of reaction if it isn't going well for them too. But the physiology for this one is a little, well, I'm way oversimplifying this because we don't have 6 days to kind of go through, nor do I, to be frank, I went to medical school too, but the immunology is kind of, it's a heavy hitter. So you have natural killer cells and you have cytotoxic T lymphocytes. You have a cell, it's happy doing its thing, it gets infected, it gets malignant, something doesn't look right in that cell, you have the release of the receptors. These two cells listen to those receptors, they release their cytokines, and those cytokines induce apoptosis in the cell. The cell, basically terminates itself, that's the end of it. And the whole system shuts down, and we're done. And then these cells go back on control, and they wait for the next cell that says, hey, I'm infected, and then that's how this works. In secondary HLH, what happens, again, way oversimplified, is for some reason, instead of this shutting down and stopping, the natural killer cells and the cytotoxic T, they just keep spitting cytokines out. They don't stop, and it just keeps happening and happening. And as you can imagine, a massive cytotoxic reaction in the whole body causes some very significant problems. Why it keeps happening is not really well understood. There's some suspicions that it's the toll-like receptor 9. There's some mutations there that happen with some malignancies and some infections, but it's not one of those things that we say, I don't know, and try to postulate as to why it is. But the association with malignant cells is that it's primarily with lymphomas and leukemias of T cell and natural killer cell origin, understandably because those are the cells that are affected and release these cytotoxic granules. It's also been found that many of these patients simultaneously have a coexisting infection. Whether we find it on autopsy, we find it during treatment is another issue, but it's also been associated with anaplastic large cell lymphomas, early B-cell ALL, myeloid leukemias, germ cell tumors. Very, very rarely there's some case reports of some solid tumors. So you have to keep it in the back of your mind, but most of the time you have to worry about T cell or natural killer cell origin leukemias and lymphomas when you're thinking about this condition. And again, the coexistent infection could be anything. Again, EBV and CMV do a lot of things, but there's cases of it with a bacterial infection, then some in a malignant patient or a patient that has a malignancy, then causing this reaction. Postulating, again, they have a broken immune system anyway, they have a malignancy that's deriving from their immune system, and now you hit them with a massive infection. Somewhere in there, that broken circle, this happens. So it's just something to consider. The diagnosis is a little bit more complicated than our other ones, but there are very good guidelines. This is a massive study from some really smart people in 2004. They have some really good guidelines for us, and they're still mostly used today, with some exceptions we'll get to. But when you're considering this diagnosis, particularly for secondary, you have a patient that you know has a malignancy or you suspect has a malignancy, and then you also notice other things, fevers, splenomegaly, cytopenia, at least 2 different cytopenias. I guess let me use this, you can use the pointer. hemoglobin, platelets, and neutrophils, and they lay out very nicely what the typical criteria are. The triglycerides and fibrinogen, as well as checking ferritin. So a lot of times in these patients, it's tests that you don't always think about. Should I order a triglyceride on a patient that I'm worried? But sometimes it can be helpful, as well as a fibrinogen and a ferritin. You can also, there's other more advanced testing, like testing for soluble CD25. The article goes on nicely to discuss some more advanced testing you can consider if that's something you want to go into a little bit more. But typically, HLH is one of those things that if it's on your differential and you have enough things to suspect it, you probably want to go ahead and treat it because it does have a pretty high morbidity and mortality. As far as the treatment, the standard for a long time has been etoposide and dexamethasone. So etoposide has kind of an anti-cytokine effect, hopefully depleting the cytotoxic T cells if you just turn off the fire hydrant, and then the dexamethasone can hopefully kind of calm the inflammation that's already happened, and the patient starts to recover. With the protocol from the HLH study, they laid out nicely again that the 2004 review, over half achieve a 5-year survival from this condition, but that's how dangerous this condition is. We're excited about over half achieve a 5-year survival, so that's something to consider. A new player on the block is anakinra. So anakinra is it's only been out for 5-10 years. It hasn't been out very long. So what it is also it's a cytokine therapy. It's much less toxic. It's recombinant interleukin-1 receptor antagonist, but it basically it does similar things in this condition that etoposide does, but it is not nearly as dangerous as etoposide, a cancer therapy. It's showing pretty good promise. It's much less toxic. There's been some very good case series of patients. There was one in 2020. Actually, one of the authors was one of our first residents from here that went on to rheumatology fellowship, and the rheumatology, and then graduated, and they work in somewhere else now, Alabama, something like that. Anyway, but there was a very good, it has some very promising things. It still has to be proven a little bit more, but it's very promising. There's some good studies currently comparing these two therapies. But if you're considering that is it a new immune modulating medication or a chemotherapy, here's your winner. I imagine it'd be kind of hard to have a study with these two, because if you're trying to get consent from a parent, I can give you chemotherapy that has we're happy if it works 50% of the time, or I give you this new drug that these data shows is pretty good, we're going to randomize you. They're like, no, the new one's fine. So that may be a little twist in trying to get good studies in this. The other things you have to consider in these patients, obviously, is some very heavy support. So hematologic, they're already going to be pancytopenic in the most cases. They are exceptionally high bleeding risk, so you want to keep the platelets at like 50,000. They're a little bit higher than our typical hemonc patients in most cases, particularly for they have some pretty bad pulmonary hemorrhage. If they have CNS disease, which usually during this evaluation they'll go ahead and get a lumbar puncture and evaluate, you have to consider giving intrathecal methotrexate and hydrocortisone. That's also, as you can imagine, a very poor prognosis in these patients. Also have to consider at one time they used to use cyclosporine pretty frequently along with the etoposide, but that has for whatever reason, this condition is a very bad side effect of Press syndrome, the posterior reversible encephalopathy, which you already have a patient which you have neural conditions or you have neural concerns, then you add that into their problem list. That's not a good thing to do. So it's not used as commonly, but it can still be used as a salvage therapy if you're really having problems. Unfortunately, particularly before anakinra, a lot of these patients went on to get bone marrow transplantation was the curative therapy for these, if that's what it had to come down to. And the last case, well, we're doing okay on time. So D is a 17-year-old female with new onset acute promyelocytic leukemia, APML. And she started on all transretinoic acid ATRA therapy. It's a pretty common therapy for this. She's feeling good, life is great. She goes home for whatever reason. 5 days later, she presents to the emergency department with respiratory distress requiring intubation. Labs are significant for extreme coagulopathy in the emergency department at the outside hospital. So this patient has something we're concerned about called differentiation syndrome. So it's a phenomenon that occurs when patients with APML, which is a relatively rare type of cancer, it's a subtype of AML, treated with ATRA and or arsenic trioxide, ATO, we're going to just say those two to make it easier, which is typical induction therapy for patients with this condition. It can occur in some form up to a quarter of these patients. So it's not a small number. Now, this is a rare cancer. APML is not super common. It's an adult cancer typically, but when it hits, it's usually the teenagers that'll get it. So you have to think about that in the back of your mind if you have a patient with this. So this is a relatively simple pathophysiology. Again, I'm oversimplifying, but you have the promyelocyte, the bad cancer cell. We're giving ATRA or arsenic trioxide therapy. What's supposed to happen is it degrades PML, RAR alpha. It kind of blocks that whole mechanism that's broken. The cells fully maturate. the cancer starts to get cured. I mean, this therapy has like a 95% success rate when it works properly. I mean, it's wonderful stuff with things we've had for hundreds of years and been poisoning people with, like arsenic. So it's really wonderful. But something happens, and that's the kicker, is the something is we're not exactly sure what the something is. They have suspicions that there's cellular migration problems, interleukin release, vascular problems, but something happens in this process in these patients, and they have a massive inflammatory response with significant tissue damage. The diagnosis is mainly clinical, but, and this is a wonderful review that they had out of Spain a few years ago that kind of breaks down the percentage of the symptoms that you'll see in these patients. But the moral of the story is you have a patient who's on arsenic therapy or they're on atra therapy, and they come to you with these problems. This needs to be in the back of your mind and thinking about it. All of these symptoms are pretty scary. The bolded ones are the ones with the ones I guess that I think the authors were a little bit more scared of, rightfully so. But you can have pulmonary symptoms with infiltrates, dyspnea, edema, unexplained fevers, pleural effusions, renal failures, hypotension, and sometimes even pericardial effusions. But if you have one or two of these symptoms and you have a patient who's on this therapy, particularly early, the earlier these symptoms occur when you're on this therapy is the concern that this is a more severe form of the disease, then you have to start to think about this diagnosis. Why I bring this up? So the treatment is as fast as humanly possible, start them on steroids, start them on IV dexamethasone. If you smell it and you think about it, get them to the hospital, start this therapy as quickly as possible. The problem is, you might ask, well, why don't we just give everybody dexamethasone when they start therapy if it's the treatment? Unfortunately, there's not great data to suggest if this is already happening, the dexamethasone may not do anything except make them look like me and lose their hair and get fat. So if you start it when they don't need it, it may not help, and it just causes more problems with giving, and this is very high dose dexamethasone. So we don't do this to everybody because it's a quarter of the patients, that means 75% of the patients are going to get them unnecessary, exceptionally high dose steroids and cause problems. So when you smell it, you have to get them and have to start therapy. Also, especially severe cases, it's significant supportive therapy. A lot of these patients end up intubated quite quickly due to the pulmonary hemorrhage, the pulmonary edema. The renal failure is pretty pronounced and pretty rapid, and a bone renal replacement. So, but the key is to start the IV dexamethasone. But another reason I bring this up, there's some newer therapies on the block, and this is where you might get caught. You see some of these medications in Epic, and you have a kid that's a new onset cancer. They come to you because you've been the primary care for 16 years, a 17-year-old kid. They know they have cancer. They started this new medications that are maybe better, ivosidenib and enicenib. I probably butchered that, I'm sorry. And it's been a couple weeks, so you're thinking, well, differentiation syndrome usually happens the first like 10 days. It's like 3 weeks, but they have trouble breathing and they have a fever. Should I worry about this? So these medications are newer ones that are sometimes used, not often in this country nor in this hospital, but sometimes used in place of the atra and arsenic therapy. They work in non-M3 subtypes, which is that's more getting into the deep oncology. So it makes a rare cancer, then you have a rare subtype. So it's not the general subtype of this rare cancer, but that's where they work in. But they're advertised and technically have a much lower incidence of differentiation syndrome, which is why they're starting to become more widely used. The issue is that in these patients, the differentiation syndrome can take several weeks to happen. So in typical differentiation syndrome, they're on atra or arsenic trioxide. Usually, if you can get through 10-ish days, particularly the first few days, you don't have to worry about this as much. The cells have maturated, whatever the heck would have happened by now, we're out of the window for this. But if you're on these new medications, it can take a couple weeks for this to kind of cook. And it may not be necessarily, it may not be on the differential because it's been a couple weeks, they shouldn't be having this, but still think about it. So that's why I bring this up. The patient we have was on typical therapy, and it happened within, I think it was like 48 hours. It was quite rapid. They didn't even get discharged from the hospital. So luckily they were still in hospital and were able to come to the ICU and get the therapy that she needed. But it's just something to consider in these patients as far as if you're out in the world and doing things and you see this medication and you have this patient and it's been a couple weeks and things are supposed to be looking up, but then something's not right. Call your friendly, which I know we all would do anyway, but call your friendly oncologist because there might be something going on. So I have some MOC questions for us because that's what we do at Grand Rounds. So everyone online wants to click some things. Which of the following is not associated with tumor lysis syndrome? Hyperkalemia, hypercalcemia, hyperphosphatemia, or hyperuricemia? Which of the following is not associated? Wants to think about that one? Yeah, I think you guys all got it. But got some people coming in online. Right on. Awesome. A lot of B's. That's great. Good job, everybody. So hypercalcemia is not associated. The other hypers are hyper-K, hyperphos, hyperuricemia. Remember, the hyperphosphatemia is the primary problem, causes hypocalcemia. But kind of tricky a little bit. But try to remember that, particularly if that may be something that might be like a board examination question, but it's also clinically highly important. But also, last MOC question, which of the following is a standard recommendation when treating HLH or hemophagocytic lymphohistiocytosis? I didn't put indicator in there, that's too easy. Even though that's what we're doing most of the time. And it works, it's a beautiful drug, it works wonders, but a lot of A votes. Wonderful A votes in the room, is that what I'm hearing too? Good job. All right, so etoposide is one of the quote-unquote standard therapies for HLH. Daunorubicin is not really, and rituximab not really associated with HLH treatment. It's just in there because they're cancer drugs. Yeah, I thought I could trick you. Cyclosporine, remember, that's one of the ones you consider in salvage therapy, but it's not a standard. It has some problems. It has Press syndrome, Press syndrome problems and things like that. It's more of a last-ditch effort for refractory cases. But well, I appreciate you guys this time. Had a lot of reference. I'm happy to send this to anybody or send you a little PowerPoint if you want to look things up. A humongous thank you to Dr. Borowicz and Dr. Ward, our own attendings here. Make sure I don't make too big of a fool of myself. I really appreciate their help. Would have been possible without them assisting me. And that's really what I got for you guys. I appreciate you coming.